We've got Nan on, fabulous. And you've got your COVID kids background, which is even better. Crystal, are you happy for me to get started?
Yeah, that'll be great. Thanks, Emily.
All right, fabulous. So welcome everyone to the COVID-19 GP community update with all things COVID. So it's wonderful to be here with Adelaide PHN hosting tonight's webinar. And we've got a number of presenters with us. We have, first of all, Jenny Gould, who's representing the GP assessment team as the clinical lead. We have Dr. Danny Byrne, who's the chair of the ROCGP SA and NT Council, and all things COVID vaccination and COVID, which is fabulous. So we're looking forward to his thoughts on things. We've got Dr. Melanie Smith, who is the current GP liaison working in the COVID special projects and SA Health. And we have Nan Vasilunas, who is the wonderful paediatrician at COVID Kids and has done an amazing job setting up that program at the Women's and Children's, and myself, Dr. Emily Kirkpatrick, who I think most of you know me, SA Health. So what we'll do, we'll get started, and look, it's going to be a bit of a marathon webinar tonight. There's just so much that we wanted to talk about, and we've been inundated with questions, feedback via social media, and also coming in through to the PHN. So we're very, very keen to answer as many questions and really bring everyone up to speed with where we are currently with COVID here in the state. So I'm going to share my screen first of all, and I'm going to really hope that this works. I'm not at my work computer, I'm at home. Now let me. And hopefully you can see.
It's working.
Fabulous. So you can only see I think you can see my slides on the side though. That's the only thing. Is that all right? Just going to fix that up. Hold on. Sorry. All right, hopefully you can now see my screen in a better format now.
Yep, perfect full screen.
Fabulous. All right, so let's get started. So there's quite a number of things that we want to talk through tonight, and we're going to go in order really of some of the key areas. We're going to talk through around the community update for COVID-19, the different pathways, and where we've changed our pathways this week, and to try and really get the message out about how we're dealing with the thousands of cases that we weren't expecting here in the state. Then we're going to move along to the current GP assessment team and where things are up to from Jenny Gould's perspective, and particularly focused on the IV infusions, the referral processes, how you can really get help for your patients in the community. Then we're going to move on to Nan, who's going to talk through around the COVID Kids program, particularly the volume that they're seeing there, what you can expect for kids with COVID and how you can refer your patients into that system. Then we're going to move on to Danny, who's going to talk through around community update, face-to-face, telehealth, all things that are really relevant for keeping your practice COVID safe, and particularly we'll be answering questions around vaccinations, no doubt. And Mel Smith will then finally update us on health pathways and where things are up to with the COVID community response, and has been doing a fabulous job in the GP liaison space, answering so many of your questions via email. So let's get started on the pathways. So I'm going to go through where we're up to now with the Omicron system-wide response. You might recall back at the end of November, December, we went through the Delta system-wide response and where we were sitting. Of course, we're in a totally different space now. We have 99% of our patients being managed in the community in home-based care, 0.5% in our supervised supported COVID-19 care facilities. So just for background, we have 2 hospital and hotels currently, which were essentially our Medi hotels that we've transformed now to providing a higher level of care for people who are COVID positive, really often for social reasons or people who are living out in really regional or remote areas. We also have a number of supervised COVID-19 care facilities now here in the state. So for instance, we have the Wiltshire Boarding House, which is specifically focused on the APY lands for close contacts coming down to Adelaide. We also have a DASA set up now, and we have a number of sites that are currently being worked up over the next 2 weeks to come online and support as required. And we've had sites being set up in down in Mount Gambier, Port Augusta, and in Ceduna today. We're looking at another site as well. So there's a lot happening in the regional rural space to provide supervised and supported care facilities. Then finally, we have the hospital care. Now, at the moment, we're sitting at 0.6% of admissions into the acute space, and we've announced in the last couple of days the expansion to the north and the south. particularly for COVID care clinics. And we found as well that there've been a factor in reducing down our hospital admissions. So 0.5% is really where we're aiming for. The modelling puts it at 0.7 based on interstate numbers around admissions, but we do need to factor in ICU admissions into that, and we've got 22 people currently in ICU at the moment in the state. So that's a little bit about where we sort of changed that pyramid, and Mel doesn't like pyramids, she's told me. So we'll stop, we won't go on any more about that slide, but certainly we've changed around the modelling, and most people do very well in the home environment if they're supported. So this is our system-wide response pathway, and you might recall this looks a bit similar to the diagram we had last time, but we've completely changed the statewide community COVID Omicron patient care model, which is really now focused on how do we expand out the model of care so that we could make sure that we could look after 30, 40, 50,000 cases in the community. You might recall we had 3,000 people we were expecting, and we had predicted from our modelling that would probably be about February, March that we would see that number go up. So really different to where we are currently at this point in time. Certainly restrictions have played a big role in reducing down the numbers that we've had here that came in, it started on the 27th of December. So we're very, very fortunate that we've been able to really flatten down and haven't seen the huge cases that we have seen interstate. And so far that's really quite pleasing to see. I'm going to go through this model in a bit more detail, but we've got lots of different clinical support models with DASA. We've brought back in Wellbeing SA in the Metropolitan Referral Unit, or MRU, as you might recall, and we're moving through different care models at the moment. All right, so I'll just go through this diagram because I think, and we will make all of these slides available, so please don't panic, and we're going to send these out as a proper pack before they go up online on the website. But this is our current statewide community COVID-19 patient care model. So everyone in the state is getting notified that they've got a positive SMS result. It tells them to quarantine, isolate after they've received their result. And that information now flows directly into SA Health from all of the labs. We then send out an automatic SMS survey out to every single positive case in the state. And that survey contains both public health and a clinical risk assessment. And it takes about 10 minutes or so for someone to complete the survey. That information then comes through into our systems in our COVID response care team, and it triages people into different risk categories. And we've been very fortunate now that we've moved to an electronic record system. So it's an automated algorithm-based system to really speed up our processes. And we've been very fortunate that's come in the last week, because we were finding the volume of cases was certainly, we weren't keeping up with the demand that was coming in and the resources that we currently have. We've now set up a home quarantine management team, which used to be running our home quarantine health checkout. They are now at the front end of the phone system. So we took on board a lot of feedback. We've completely redone our phone systems end of last week, this week. So it's all streamlined and categorized where people are in the system. So it's an administrative person who answers the phone call. You get triaged into different systems. And when you call up our COVID response care team number on the 1-800-272-872 number, it's really easy now. There's a whole selection of numbers, and it enables you to be triaged. And hopefully very soon, we'll have our GP clinical advice line that will also come through that number to speed up how you can get in contact with everyone. We then send out daily SMSs, which ask around whether a person needs clinical support or logistical support, and also their symptoms as well. So we have a low, medium, and high risk pathway. Now, the low risk pathway is where we've made the changes in the last week. And this is around how can we get people to self-manage at home. And what we're encouraging people as much as possible is to contact Health Direct if they need general care advice. And we've been working closely with Health Direct in that space, or to call in if they need support. And finally, if they have a usual GP, to contact their usual GP, because generally the problems we are finding people are calling in for are completely unrelated to COVID, particularly if they're in that low risk pathway. So these are people with very mild symptoms who are at home, who are otherwise doing quite well in the vaccinated space. We then have a medium risk pathway, which moves across to our nursing team, contacting people based on what they put in their survey. And then we have a high risk pathway. Now, this is the pathway where our GP assessment team gets involved, and it's particularly focused on the immunosuppressed individuals aged over 65 with a chronic disease and pregnancy in the high risk pathway. And as part of that, it's those people who get the COVID care kits, which are the SATS probes and temperature probes sent out. At this stage, it is not the other people. Unfortunately, we didn't have the volume and supply, and we didn't feel it was necessary to be sending out people with oxygen SATS probes if they were otherwise pretty well in the community. So if someone does does see one of our GP doctors, then they can absolutely be sent a kit if they do require it, if their condition escalates. And then we have our COVID care centre referral pathways, and we've got Jackie here doing a fabulous job in the COVID care space at the RA, and a number of new sites being set up. We now have 6 regional rural sites, and it's been great to see that everyone's been taking this on board in the regions. And we have the North coming online this week, and Salem started a couple of weeks ago, really focused on the pregnancy IV infusions for sotrovimab, and I'll go through a little bit about that process in a minute. So that was the pathway. Or did I cover everything? Probably I missed a couple of things. The automated clearance, the 10 days is probably the point just wanted to emphasize. So we are now in South Australia running an automated process for clearing cases at day 10. So that's regardless of someone's symptoms. The only time we do not clear is if someone is admitted into the acute space. Otherwise, is an automatic clearance. At day 10, a notification is sent to advise the person, and they're sent an SMS clearance. So we used to send a letter, it's now an SMS, and that's been acceptable from Commonwealth standards with an SMS with a name and date of birth of the individual. There's no requirement to have an exit swab when clearing out and being discharged out of the program. It is 10 full days, and day 0 is the day the test is taken. So it ends up being a little bit longer than 10 days, and noting it's 7 days in New South Wales and Victoria. So that's a little bit about the pathway. So we'll, of course, make this really accessible and available. But what we wanted to say and really bring you on this journey is we acknowledge the fact that we absolutely need to start at some point now integrating back into usual GP care for mild and low risk individuals in the community. But we need to really emphasise that for those who are at increased risk, unvaccinated, chronic disease comorbidities, they need that support and wraparounds that can link into the local health networks. So we will be still maintaining a very strong COVID response care team, but about 65% of people on our numbers appear to be in the low risk pathway and otherwise are doing quite well. And this seems to be very much a picture of Omicron, and certainly wasn't where we're at with Delta. In terms of the risk assessments, we have based our risk assessments off the National Clinical Evidence Task Force, so it does align with the RACGP criteria and guidelines, which are fantastic, into the low, the medium and the high risk admissions. And we've changed it around now, so people who are medium risk are staying at home rather than coming into our hospital and the hotel environment. We've also changed around our disease severity levels and the clinical risk factors, as I said, with our algorithms that we've put in place as part of that initial screening survey. Now, if someone can't complete the screening survey or they don't have a mobile phone, we have our call centre that are calling up people who don't respond within a 24-hour period to see how they're going and to fill in the survey on their behalf. In fact, we find the majority of people do the survey. It's mainly around aged care and corrections where we don't get surveys being completed at this point. And we're working through, of course, mobile phone numbers and making sure that we've got everyone's details from their PATH testing as well. So we based it on the Clinical Evidence Task Force guidelines into that low, medium, high and very high risk pathways so that we're aligned. So it means it then sits with the RACGP guidelines as well. We wanted to make it as easy as possible, and we didn't create new categories here in the state. And we've aligned that so it's quite clear around home support and high risk in the hospital space. Health Direct is a really interesting space, and we're really hoping to be able to utilise Health Direct further as we come into the coming months, particularly around lower risk patients in the community. And we know that they're doing a great job interstate in terms of helping to triage and assess patients. So rather than just being that phone support, actually doing the assessments, and we're hoping to bring them on more into this space as we move forward. But I'm talking too much, but usual GPs do provide of course, such important care, and we know it has been around the non-COVID care that's of most importance. I'm going to cough, sorry. I needed some water at my desk here. All right, so as we move forward, we know that there is certainly a need to get more information, and we are upgrading our phone line system so that people can call in directly and access the CRCT clinical information line, and we hope to have some information out in the next few days. Otherwise, just keep emailing through to our GP liaison email address. Medium risk pathways that we've developed, and particularly around hospital and the hotel, transfer into the COVID care centres, and our high risk pathways as well. But we'll make this all available so that everyone can see this information. I'm just going to give a bit of an update on booster vaccines, and really just around what this means is there has been a recent change in direction in this space. So it is now a requirement under the direction to have a booster vaccine if you are mandated as a healthcare worker. And this is as part of the healthcare worker vaccine direction number 5, which will come into effect at the end of January, on the 22nd of January. And this will, the 29th of January, we ended up pushing it back a week because we were delayed a little bit. But essentially, this does require individuals to have a booster dose within 4 weeks of becoming eligible. At this stage here at SA, it is still 4 months after the second dose, but there is active work to look at bringing that down to 3 months, as you might be aware with current ATAGI advice and criteria. Next thing I want to mention, I'm conscious I was meant to be quick, only 15 minutes, so I've gone a bit over my time, but hopefully we can come back and cover some of this, is the vaccine EOI. We sent out an EOI last night for expressions of interest around additional paediatric doses. We'd heard some feedback that there was a desire to have more doses within general practice and in pharmacy. So we have an EOI that went out last night by the GP update and has also gone out by pharmacy networks as well to encourage people to apply for additional vaccine doses, 400 doses of the paediatric Pfizer, if there is if practices have an additional demand or need, and those will go out over the weekend. So please apply via the EOI if you are interested in that. The next thing I just want to quickly mention is staff furlough, which is always an area of a topic of conversation that we do like to discuss and talk about. The furloughing is very interesting and particularly has been very topical over the last week as we changed our close contact matrices, and particularly focused on those who are in an indoor space greater than 15 minutes not wearing a mask, that was part of the close contact exposure, and someone would be classified as a close contact if it was not in a household environment. So we are in the process now of just updating the advice further around community care exposure. And what I want to emphasise is essentially we want to make it as safe as possible for people in the workplace, but also provide people the opportunity to come back to work if they need to as part of critical work. So there will be some criteria coming out in the next day particularly around PCR and antigen testing to enable close contacts to come back in under certain conditions. The other aspect as part of the staff furloughing that is important to emphasise is there is still a requirement to wear an N95, particularly if you are in that clinical setting. So that doesn't change at all current PPE requirements, but I'm happy to talk through that and post a little bit more in the chat around those areas. I'm going to leave it there, but I'll come back to certain areas as we move throughout tonight's webinar, and we'll be happy to post and answer questions in the Q&A, because I no doubt there's a lot of areas that people are really keen to explore further. But my 15-minute presentation is up now, so I'll hand over now to Dr. Jenny Gould, who's going to go through around the GP assessment team and through some of their different processes as well. And I'll stop sharing my screen. The other thing I didn't talk through, and probably I just was going to mention, is we are just launching now our new centralised referral process for IV infusions in the state, and particularly referrals for people to have IV Sotrovimab infusions. So I'm going to put the details up around that site in the chat. I'll just see if I could show you on my web page, but I'm probably not savvy enough at the moment the way I've set my computers up here, but I'll post it in the chat. But it's a centralised referral process now for IV infusions here in the state, which is just fantastic news that we've been able to do this and had agreement with the ID physicians, which will enable GPs, GPAT doctors to be able to refer in across the state for Sotrovimab. It'll make it much easier for you to be able to refer your patients in if you know that they meet the criteria. So that's probably all from me, and I'll hand over now to Jenny, who's been doing a fabulous job in the GP assessment space and lives and breathes COVID, as she has for the last 21 months. I think Jenny's been working for us now and doing an amazing job looking after COVID patients in the community. So thanks, Jenny.
Hello, everyone. Crystal, I'm having trouble sharing my screen. Are you able to bring up my presentation? I don't think anybody can see that, can you? COVID Care Community GP Assessment Team.
Yes, we can see it. Just make it full screen, Jenny.
Oh, there you go. Look at me. I'm cleverer than I thought. All
Perfect.
Right. Fabulous. I think what I wanted to say is hello and welcome to all of our fabulous GPs and panelists. You're doing a fabulous job, and we would not be able to do this without you all. And I think Emily's covered this really well. We're looking at a very different space with Omicron, where 98% of patients who are positive are able to be managed outside of the hospital. So of course, they will be seeking the support of their fabulous usual community GPs. So increasingly more and more people are going to be reaching out to you. And I think, you know, as GPs, we all have the skills to manage viral illness. And for most people, this is going to be a very mild or moderate viral illness, which is just going to require symptomatic treatment and support during that journey. And only a very small proportion of people are going to be identified in that at-risk group of deteriorating or getting severe illness. And what we're hoping that we are doing is capturing those through the processes that Emily has talked about, and that they are coming under the care of the GP assessment team and leaving those, well, you know, on the whole, well people with under your fabulous care. So my focus is really going to be on how GPs in the community and what you can do. Of course, we are going to keep working in our space that we have been working in with GPAT and looking at that higher risk group. The community GPs are, of course, essential. And we have been referring back to the usual GP for non-related COVID care, even in our COVID positive patients. This is so that we can focus really on looking at the COVID illness and recognising people who are at risk or who are struggling, and provide them with that acute care they need in that space. So things like ongoing scripts and care plans and all of that stuff, we've been encouraging these people to come and find you. I've talked about this being a viral illness. Of course, it's not like any other viral illness. COVID is new and, of course, creates a whole lot of anxiety. I think Omicron is a different kettle of fish. We're not certainly seeing people anywhere near as sick, and that's a great thing. So we're having much less hospitalisation of these patients. So I think focusing on the usual things that you would do for patients that you are seeing in your practice with a viral illness is exactly the same here, but with a slight added twist in that, of course, we've got those risk factors that are clearly identified for those people who are at risk of deterioration, and that certainly might require and will require closer monitoring, and looking for that sort of day 5 to 7 cytokine storm where we can see deterioration. And of course, there's also that other added component about people who may be eligible for disease modifying treatment or monoclonal antibody infusion. And with that having a window at which we can provide that care, then it's important that we all work together to make sure these people are getting identified and getting to the get access to their infusion should they be eligible and should they wish to undergo that path. I think also it's really important, as Emily was saying, about the survey and the daily symptom checker. That's how we identify those patients who are in need of more support. So encourage your patients to complete those, and, you know, obviously keep on with all your positive messages around vaccination and following the precautions and PPE, etc. The risk factors, I think I've harped on about these a lot. Everybody's aware of them. There are medical risk factors and social risk factors. And we also have that group of immunocompromising conditions or immunosuppressive medications that put people at particular risk also. You will be in very strong positions as the community GP to know which patient groups of yours that will fall into these categories. And I'm sure as I talk, many of you are already thinking about patients should they become positive and therefore they would be at risk. So working with you guys as the GP in this space is really important. I think the sort of things that I've been seeing in mainstream general practice and that I'm hearing is, and that what we envision patients will be reaching out to you about is ongoing normal general practice type care and routine care even in that setting of being COVID positive, obviously through telehealth, they will be seeking lots of support and reassurance and advice, things that they would not necessarily check in perhaps with any other virus or cold that they got, but because they're COVID positive, that comes with a whole another level of anxiety. And I certainly think for families with children, given the sad circumstances we've had in SA, there is a heightened anxiety there as well. GPs will have that awareness of those who are at risk and be able to check in or monitor potentially. We'll advise you about the escalation pathway, so you know how to where to send your patients to get increased or help if they need face-to-face medical care. Having that knowledge of the eligibility for the monoclonal antibody infusions in those at-risk groups, which Emily's already identified. Knowing that, you know, patients who are not fully vaccinated, or they may be vaccinated, but they are immunocompromised such that their vaccine may not be effective, then that group, if they have an additional risk factor, will meet criteria for monoclonal antibody infusion. Pregnant women also who are unvaccinated or immunocompromised with a risk factor. Clearance, I'm sure you get lots of questions around clearance because everybody wants to get out of isolation. A life after COVID, when to have their next vaccination, should they retest, what about other people in the household, returning to work, all of these things are questions that are going to come your way. And I think the mental health burden, and I've talked about this a lot, but I think that's still very real for patients as they journey COVID, and that will be obviously an area that falls to general practice. And of course, you will be working in the SCOVID or the suspected COVID positive space as well. I think to know where we're up to with all of these things, the SA Health website is up to date, and the SONG guidelines, or the series of national guidelines, or the CDNA around COVID, is constantly updated. And I think having a saved favourite link to that is really important. It will date when any changes have occurred, and it will highlight those in yellow. So you don't need to reread the whole thing. You can quickly look at it and you can tell if anything's changed since you last looked at it. And it's a really reliable way of knowing what's changed in the national guidelines. Doesn't always mean South Australia's taken them on though, but nonetheless. I think this is preaching to the converted. You all know how to manage viral illnesses really well, the common symptoms of COVID, and I think it's really important that patients are encouraged to have paracetamol and anti-inflammatories. Wasn't it? I don't ever get time to watch the news, but I think one of the premiers was telling everyone to go and buy up their anti-inflammatories the other day, so you probably can't buy them anyway. Antiemetics is something as GPs you might be involved in prescribing if people are having severe gastro issues, and hydrolyte is something they can get. Sorting their other comorbidities, if you've got someone who's got underlying asthma or airways disease, really important to get that well controlled and stable, and to manage that in that acute viral exacerbation. Budesonide doesn't seem to be the wonder drug that everybody thought it was, and Victoria wanted to put it in the water almost, but certainly if you've got someone that you would normally think about putting on a preventer in that acute viral respiratory illness space, then can certainly do, and you can, if they're not on one already, you can add in budesonide. And of course you need to manage other things that might happen along the way, secondary bacterial infections, sinusitis, whatever comes along. I think the other things outside of that symptomatic management are really the prophylaxis, the post-exposure prophylaxis, but we're not really using that because Ronapreve is what we would use in this space, and it's thought to be very limited effectiveness in Omicron. So we haven't been using PEP. Of course, Sotrovimab is the monoclonal antibody that's being used in this space for those people who are eligible. And we have very clever hospital doctors for that small percentage that end up in there that are able to manage those more complicated medical needs. Other issues that come along are things like, accessing medications from pharmacy and food and mental health and other issues. And of course, as GPs, you're very familiar with your local communities, and I'm sure you're able to assist. And we also have the COVID response care team who are able to provide resources in this area. I think, again, it's no different to any other acute setting. If you've got someone who's got red flag symptoms, chest pain, an acute abdomen, those sorts of things, you are sending them directly 000 to ED. That doesn't change whether you've got COVID or not. Of course, then we do have the red flags around COVID. And I think probably the biggest one is if we've got access to oximetry, if we've got readings less than 95, and we're sure that's accurate. I mean, we have had some people with beautiful acrylic nails that affects their oxygen sats, but if you've got someone, you need to use your clinical nous as well. I mean, if they're sounding well, they're talking, laughing, moving around the house when you're talking to them on the phone, they probably don't have a true sat less, under 95. But in general, if you've got someone with reduced oxygen sats, then that they should be sent for review. And of course, other things that might need face-to-face. This is where the COVID care centres are coming into their own. We've had the one at the Royal Adelaide, which I think is almost bursting at the seam. Flinders has come on board, Narlan are coming on board, and as Emily said, there's some in the rural and regional areas. So these will play a key role in providing that face-to-face assessment or IV infusions for fluids, as well as the MAB for patients that will require them. And of course, there are other specialty areas in this space. Flinders are looking after the COVID positive pregnant women, and we have the fabulous COVID kids, which we're going to hear from a little bit later tonight if I get moving and stop taking up all the talk time. This is just a table which shows about symptoms, and I think this is from the national guidelines, but I think, as GPs, you're pretty comfortable with assessing a viral illness. Sotrovimab, which we've talked about, it's for adults or children over 12 with over 40 kilos. So if they're not fully vaccinated, and fully vaccinated means that the second dose is more than 2 weeks ago, and that more than 2 weeks ago, or less than 5 months ago if they've had Pfizer 2 vaccines, or less than 4 months ago if they've had AstraZeneca. So that definition has changed, as Emily referred to. It's no longer 6 months, so we've brought that back. So if someone is not meeting that criteria of being fully vaccinated, or their vaccination status is in question because of an immunocompromising illness or an immunosuppressive medication that may mean that vaccination hasn't had its full effect, then that's the group that we're assessing for a MAB. Complicated diagram, don't expect you to follow this completely, but it just shows you that we've got, in this space, we've got, this is non-pregnant patients. If they are immunocompromised or not fully vaccinated, then they will move down this path. If it's under 7 days since they're on a symptom onset and they meet criteria from these boxes, then they can be considered for sotrovimab. Likewise, if they're pregnant, they go down another pathway. If it's more than 7 days, then they've really passed that window and they're not eligible. That's it in a nutshell. This is just a diagram which goes through all of the weird and wonderful things that make up what's the definition of immunocompromised and which drugs we consider and don't consider. And these are all things that I do not prescribe on a very much of a daily basis, in fact, if at all. So I'm not sure that any of my patients would be on these, but you may well have patients in this group. This is the pregnant MAB pathway, but I won't go through that. That's very similar. And again, that would be done through Flinders. And then I think the big one that patients ask all the time, and Emily's already covered this, is the 10 days clearance, with day 0 being set from your positive test, doing a full 10 days and clearing after midnight. And that will be automated, that will be set from their swab, and they will receive an SMS message And there's lots of debate in this space, certainly with patients that we interact with, but usually at this point, if they're talking about being cleared, they're well. So it's not really the focus of GPAT. We are trying to stay of sharing our clinical availability over those really high risk groups and those that are sick. And so, yes, the public health will send them an automated message to clear. So I think that's it in a nutshell for the fabulous, to give you a bit of a guide of what you guys are already doing, and we really will encourage you to continue to do. So well done, and I'll hand you back to Emily.
Fabulous. Thank you, Jenny, as always. Very informative. And this is certainly a very action-packed webinar. There's a lot of content. And so no doubt this will be recorded and available if you do want to go back and hear things again. I'm going to now hand over to Nan, and I'm not sure, I'm hoping you've connected okay onto your fabulous. There you are. Wonderful. Just to give us a bit of an update on the COVID kids model. And I do have a slide, if you need a slide, that I have in my slide stash for the COVID kids model. So let me know if you'd like me to show it as well. But
okay,
I'll hand
if
over
you
to
could,
you,
that would be great, Emily. I can try and share some things a bit later, but if you've got that, that would be great.
No worries. Happy to share briefly.
Thank you. And you'll probably notice that there's another Nan Vassilinas up there. That's actually John Wong, who's one of our doctors. So John, do you want to put your camera on if you can? There we go. So John's just joined us as well, just in case there are any questions, because I'm not seeing a lot of these patients now, although I do hear a lot about them. But obviously our paediatricians are seeing lots of those patients. So I thought I'd just try initially, and if I can, share some of our data. So I'll just show you, if I can share my screen, I will try very hard. Here we go. Can everyone see that?
Perfect.
Yes.
Thank you.
Yep, excellent. So this was some data that we were sent today from our clinic. I won't show all of it because it's not all of too much interest, but as you can see on the left is our daily summary. Yellow is our bed status at midnight, and then we've got admitted and discharged patients. And as you can see, it's sort of gradually climbing. I've just had a look at our admitted patients at the moment, and we've got 50 admitted at the moment. So it is just kind of gradually going up. So we're seeing lots and lots of patients a day. We've got a very high turnover though, so we're sort of admitting and discharging pretty quickly. Just on this slide gives you a bit of an idea that a number of quite a high percentage, 40% of our kids who are admitted to our service are under 1. So we have quite a lot of young kids admitted to our service. This is just telling you the appointment types that we're seeing. So the majority of our appointments with our clinicians are by telehealth, so that includes a video, and that's working really, really well. We've had a lot of good engagement with parents who really like that their child is actually being visualised, I think. So the majority of our appointments are by telehealth, but we're doing the occasional phone call as well, and that's getting more common now that we've got more patients. And we're also doing the occasional face-to-face, which I'll go through in a minute, that we have a specialised area at the back of our unit where we can see children face-to-face. And this is our growth curve. So as you can see, we're going up quite rapidly in terms of our numbers. So just a little bit about COVID kids, and I'll try to share, if I can, our referral pathway at the moment. So can everyone see that? No, okay. So I'll stop sharing and then share again. There we go. Hopefully people can see that now. Can people see that? John, do you want to nod your head if you can see it?
Yeah, it's very small.
Yeah, sorry. See if I can.
That was the slide I was going to share, so that's fabulous.
Okay. Have you got a better version?
No, that's better. That's good.
Okay, all right. So look, this is a little bit old now and due for update. The criteria remain the same, but up here, up the top, with who is referring to us is now quite different. So initially, it was a referral process through CRCT and GPAT to COVID kids, and there were a number of criteria for that referral process. We're now receiving referrals really from any clinicians, to be honest. So most of our referrals now come from EDs and from the ambulance service. We get a lot of phone calls from SAS as hospital avoidance measures. So these are phone calls where an ambulance has been called out to a family for a child with COVID, and the ambulance crew has already assessed that child as not requiring an ED. And so they ring us, and we can either do a virtual assessment on site, or we can speak to the family by phone and organise follow-up that way. So we're getting a number of referrals that way. In terms of our criteria for admission to COVID kids, and COVID kids is really a virtual assessment centre that we call a hospital in the home, but a lot of our children would not fulfil the criteria for actually being admitted to a hospital, but they are sort of admitted to COVID kids. So we accept children, obviously, with moderate features of COVID, and they're also listed there. Those with more severe features obviously need to be referred to an ED. Children with mild features can be referred to us if they have significant medical risk factors, and they're listed down there, and or significant social factors. So we do have a COVID kids social worker, and we're onboarding some Aboriginal support workers as well. So we do now have a significant number of children who are admitted who really are just receiving social support from us and not really unwell clinically. So that's our referral process. In terms of who we are, we're staffed by consultant paediatricians, predominantly from the Women's and Children's Hospital, but also from Flinders Medical Centre and the Lyell McEwen now, who are doing off-site reviews for us. The consultant paediatricians come from a number of different areas. So I've got Jackie Schutz sitting with me, who's one of the consultant paediatricians from my emergency department, who is with COVID kids, and Dr. John Wong, who's online, is a respiratory consultant who is working with COVID kids. So we've got paediatricians from lots of different specialty backgrounds, including general paediatricians. We also have some advanced trainees in paediatrics who've recently joined. And we've got lots of paediatric nursing staff who are very experienced nursing staff who are helping us as well. So we have a virtual centre set up with lots of computers and headphones, etc. And we sort of sit there and do our telehealth. But we also have a face-to-face clinic basically attached to our virtual centre, which has been basically designed to be a negative pressure area. We have to cohort patients within that space, so we can see up to 3 patients at a time, but for that reason they do actually have to be confirmed COVID. Saying that, we have a number of children admitted to COVID kids who have never had a confirmatory test, because as we know, the adults often feel pretty unwell with COVID and haven't been able to organise a confirmatory test. That does not preclude them from being admitted to COVID kids. We're a clinical service and use our clinical judgment. So if we think that a child has COVID, then they certainly can be referred to us and admitted to our service. If they're seen by face-to-face, we just have some stipulations that we make sure they're not seen in conjunction with someone who has confirmed COVID, although that's potentially going to change soon too. So they're the sort of services that we offer. In terms of the children that we see, we've seen quite a wide spectrum of children now, including we're starting to see some immunocompromised children. We've seen a couple of children with leukemia now who've done very well. And we've also seen some children with various other sort of neurodevelopmental disabilities and things. So we've started to see a broader spectrum of children in the last week or so. We haven't yet had anyone with severe illness. We've had a couple of moderately severe illnesses that have been admitted to the Women's and Children's, but we haven't yet had anyone admitted to ICU. In terms of the sorts of presentations that we see in COVID kids, the younger children, and John and Jackie can butt in if they want to, but they tend to be the ones who have difficulties keeping up with their fluid intake. They might have some diarrhea, some vomiting and poor fluid intake. So it's been around managing fluid status with those children, and sometimes they do need to come in for an assessment. And fever, yeah, that's right. So Jackie's just reminding me we do see quite a number with fevers, which can be quite significant in these young babies. And so we have quite a low threshold to review, particularly the younger babies, so those under 3 months who present with a fever. It may well not be due to COVID. COVID might be a bystander. So we just have a low threshold to bring them in and have a look at them. Obviously, a neonate with a fever, we would see and potentially probably do a septic screen, etc. And that child would end up admitted. We've seen a fair number of rashes in children, some sort of macular-papular rashes and other odd rashes. So obviously it's important to make sure that you're happy that it's an innocent rash and it's blanching, etc. So they tend to be in the infants and the young toddlers. In the older kids, again, we've seen sort of a nasty sort of flu-like illness, to be honest, sort of aches and pains, headache, diarrhea, fever, excuse me, myalgias, and it tends to resolve really quickly with Nurofen and Panadol. So if there's any questions, it would be great to get them now, or I can get questions later.
There's 505 people online, but they can't ask questions.
There are quite a few questions already in the chat, Nan. So
are there any common ones that you want me to answer?
We'll come to we'll do a bit of Q&A at the end if that's all right. We might just press through because there's quite a number of, and Mel and Jenny are doing a fabulous job getting through the questions, but we're sitting at 40 unanswered at the moment. So
right.
Come back at the end.
I guess my main message would be that this is a virus pretty in our children that is behaving like a lot of other viruses, and we're managing gastro like gastro, asthma like asthma, croup like croup, and bronch like bronch. So it's not really any different in terms of what we're doing, particularly for the younger babies with COVID. We're just providing the clinical support for sort of a standard virus. And we're absolutely here for people to refer to, and we can absolutely share our details for referral.
Fabulous, thank you. All right, we'll move now on to Danny and Mel. I'm not sure what you've divvied up the areas you're going to talk about, but I'll hand over now to either of you.
Go, Mel.
Okay, I have a couple of quick slides I wanted to share just on health pathways. So I'm going to try my skills at sharing that. Let's see. Okay. Hopefully you can all see that?
Great, thanks, Mel.
Awesome. I just wanted to, as part of this, just point, obviously many people are aware of the Health Pathways websites as a supporting information portal for GPs across the state, and they do have quite an extensive set of resources around COVID, sort of really collating all of the information around sort of state pathways and national resources. So I just sort of wanted to run through it and point out that there is good stuff there. We're continually updating it. And I know in the past there's been a little bit of a barrier to actually logging on to Health Pathways because people have had difficulty. You have to have a password to access it. They've actually updated it today, and there is now, if you go to the Health Pathways site and go to log in, it'll actually, you'll be able to get a special COVID-19 login available to you on the site that you can use straight away to log in. You don't have to sort of register and wait 24 hours to get your own personal login going forward. So just wanted to show the COVID-19 suite of resources available. They're sort of at the top of the Health Pathways page for SA. Lots of good stuff there, highly recommend it. And there's some details on the COVID-19 username and password that you can access, and the URL is there ready for you. I just sort of wanted to get that in before handing over to Danny, who I wanted to sort of give a bit of his experience, having had a few patients with COVID that he's been involved with, and how he's found the experience in trying to, and sort of working with CRCT. And then I'm going to try and show you the website around infusion referrals.
Okay. You're going to
stop sharing.
Stop sharing. Hello, everyone. 500 plus people online. Thank you, PHN, for hosting. I just want to say one thing straight up. We're basically in a disaster crisis mode, if you can think of it like that. So, you know, Emily and Mel and Jenny and the COVID kids and everyone in SA Health is doing their best. It doesn't matter where you are in the world. It's crazy with Omicron. So all these systems are set up and they're doing the best they can. So many of you might have heard that saying about don't let perfect be the enemy of the good. So everyone's trying to do their best. We know that not every patient gets an SMS from SA Health. Not every patient gets the surveys. Not every patient gets contacted. And so at the end of the day, you find out a patient's positive. What I do is give them a ring and say, did you get your SMS? And, you know, an 85-year-old lady says, yeah, I don't know what to do with it. I don't like clicking on the link. And so you just either ring the COVID care response team yourself or give that phone number to the patient. They can ring in and establish that sort of contact with the system. So we had one lady, and, you know, we just rock up at work. This is after Christmas. And there's a COVID positive just sitting in the inbox, and you think, wow, that's exciting because it's the first one we've ever had. And she was a lady that had 2 AZs, but was just 1 week short of her booster. So we were able to get in contact, and she hadn't had the SMS. It was in the early days, so maybe the system's working better now. But we got in contact with Mel through COVID care response team, and she was able to get taken to the Royal Adelaide to Jackie Yo's service and get a sotrovimab infusion. And I got a great little discharge summary back from them as well. So that worked well. I had a patient in his 80s as well. He was going along fine. He's like, Danny, I don't know what all the fuss is about. I feel fine. You know, him and his wife is positive. They're out gardening. And then on day 9, he rings me and says, oh, I'm feeling sick, short of breath, coughing. And I thought it was going to be that COVID cytokine storm crashing on day 10 or whatever. So you got to call an ambulance, go to the Royal Adelaide. It turned out he just had a community-acquired pneumonia. He was only in for a day, some IV antibiotics, sent home on Augmentin. And I rang him the next day, and he was absolutely good as gold. So not everything has to be, you know, getting admitted into intensive care and put on the ventilator and that sort of thing. People can go to the Royal Adelaide, or the new ones are going to be set up at Flinders and Narlan and the regional ones, the COVID care centres, and you know, get some IV fluids or antibiotics or patched up or whatever they need, and then chuffed back home again. So the only thing I'd be saying is that we're sort of that finding those patients who are just falling through the cracks for whatever reason. The mobile phone number's wrong, or the patient's just not comfortable with the technology, or they've got one of those old mobile phones that is a phone, doesn't do anything smart. So we have to just step in and advocate on behalf of our patients. And you have to be, like we are as good GPs, you have to be resourceful and advocate. And you know, I just literally Googled COVID kids, never heard of it until tonight. And there's a whole women's and children's website all set up that looks really nice. So just get everyone, do your best. You know, at the end of the day, I've also found a lot of the patients, they're fine. They just want to have a good old whinge about their terrible sore throat and their cough and their headache, and that they're actually feeling better usually on even day 2, day 3. So just like we listen to patients, you know, the best thing we do for them when they've got the flu is listen to them have a good old whinge and sympathise with them, and just they know somebody cares. And that then you just say, ring us back if you need, but the majority of them are absolutely fine. Maybe there is a SMS clearance thing happening, but it's not happening with my patients. So you just follow the guidelines. They ring and say, can I get out? And you say, well, when was your test? That's day 0. Let's count 10 days. Okay, so at midnight tonight, you're out. Just keep it simple. Make sure, obviously, they haven't got any symptoms. So there's no getting a clearance test. There's no certificates. There's no big dramas about it all. And if in doubt and you think you've counted 11 days instead of 10, big deal, doesn't matter. Just don't let them out on day 9. Okay. I've seen, you know, the questions are up to 47. There's stacks of chat going on, over 500 people. So it's going to be impossible to get through everything tonight. So Melanie and Emily and Jenny are going to be super busy, but they'll do their best, I'm sure, to collate all these questions. And maybe it's you know, this reminds me, unfortunately, of March 2020 and when weekly webinars were happening. So maybe we have to think about that, but I'll leave that to the clever people. So be good GPs. That's the only thing I want to finish up on, which I know you all are. The fact you're even dialing in tonight is great. I appreciate it. So do your patients. Thank you.
Thanks, Danny. I think that's a really strong message around don't be frightened, don't be advocating for your patients. We're always happy to get calls or emails asking for assistance, and particularly if GPs are able to identify that they have patients who are in need, we've been able to escalate them and make sure that they get the reviews and the support they need. So always happy to have GPs sort of speak up on that. And we certainly do have plans for ongoing webinars over the next few weeks. Next Wednesday night, we actually have time set aside for a whole webinar about the monoclonal antibody infusions. We'll have perhaps some of the pharmacists. We'll have Jackie Yo, who's done a lot of these infusions, and we'll have one of the ID physicians. And we will have had our website up and running for hopefully a good week by then, getting this sort of centralized referral pathway so that GPs can start referring directly for these infusions. And I would like to just try and share that website with you now. I know Emily was trying to do that a little bit earlier, so I'll try and do it now just because I want to gazump it. Let's try this. There we go. And hopefully you guys can see the website with monoclonal antibody infusion on it.
Perfect.
Excellent. So this is the site you'll come to. We'll have a nice, slick, short URL you'll be able to use, and we'll be getting that out to you in a GP update ASAP. And it just sort of talks a bit around it, gives some general information, talks about the eligibility criteria, and the basic criteria are that you need to be either immunocompromised in some way, or if you're not vaccinated, have some kind of other risk factor for progression of disease to severe status. So, and you do have to have some symptoms. You can't be completely asymptomatic, but by the same token, you have to have mild disease. So if you're already needing oxygen, you're not eligible for these. So there is an online form you can go to. The magic of the form will come up and you get to sort of work your way through this. I think this is one I played with earlier with some sort of just test data, and it sort of runs through all the information that's needed to actually decide whether your patient is eligible, and gets all their contact information. You know, if they have a substitute decision maker or a guardian or someone else who you need to contact to actually get consent, ask about whether they need an interpreter, and ask where they are, which is probably one of the really important things, because what we're trying to do is sort this out so that from the centralised point, we can then connect eligible patients up with an infusion centre that's close to home. So there are, as has already been mentioned, there are various regional sites where they are actually able to give these infusions now. Now Gambia, Berry, a few other places around the state. So we, rather than having to bring people to Adelaide for this, we want to make sure that they can get it close to home. And they're certainly doing them down at Flinders now, as well as at the Royal Adelaide. So the whole idea here is that we can get people access to these earlier. And as most GPs know their patients really well, earlier, as long as we can keep getting that information out to you about your patients being positive, and hopefully many of them are actually self-identifying to you, then you can actually help escalate their access to these really, really profoundly helpful interventions for COVID. So I just wanted to show that to you, and then I think hand back to Emily to walk us through some Q&A.
Thanks, Mel, and appreciate you sharing the website. I think it's a really key area that we're keen to really streamline our processes here in South Australia, and certainly we want to make sure it's accessible to as many people as possible. There's quite a number of questions about rats in the chat, and I apologise. I really should have put an update in that when we were talking through around where we were heading currently with our new system that's been developed, which launches tomorrow, as you might have been aware from the media, which will allow then for close contacts to have a rapid antigen test if they collect it from one of the designated SA Health collection sites. They need to pre-register before they go. It enables them then to get a special code. They can pick up the test, and then that is then part of the system then, so it avoids them needing to go and line up for a PCR test. If someone has a negative rat test but they've been directed to test, then they are still required to get a PCR test to confirm. And same if someone has symptoms and a negative rat test, and they still need to go and get a PCR test. So it will hopefully reduce down some of the numbers coming through for PCR testing, but we need to be really, really clear on this, that PCR is still the gold standard, and it is still the expectation that we will be maintaining a high level of PCR testing here in the state. So there's two types of PCR tests now moving forward. The first are for people who are directed by SA Health to go and get two types of rat tests, who are directed by SA Health to go and get a test, and those are the ones we need to pre-register and go and collect from one of the collection sites. And then the second group are those who do not meet a criteria under the direction but are wanting to screen. So for instance, you want to screen the patient before they come into your GP practice, or you want to screen yourself before you go to work. Now that falls outside of the direction. That's part of your own surveillance processes, and therefore that's stock that needs to be purchased and bought in. So the Commonwealth is working through around increasing supply, and their focus initially is on aged care and the disability sector, and then we'll be working through a list of priority orders from education and moving through across government into different areas. At the moment, it is very challenging to order in stock. I think we all agree that that's a problem area, and further work's been done in the Commonwealth space, and certainly aware that it will be discussed likely tomorrow at National Cabinet around a priority order for distribution. I think that's been quite put out quite publicly, that that's an area that needs to be reviewed. The other point, I think I just saw a few things posted in the chat that just wanted to go through, was around pharmacies. Unfortunately, it's really difficult to get access to rats in chemists, but that will increase the supply over the next few weeks, particularly as we see larger volumes coming in, because a lot of the stocks were put as part of aged care responses and in healthcare responses as well. PCR, we know, should only be used in symptomatic individuals as much as possible, and to avoid for surveillance testing. And certainly there's a lot of work to go to try and reduce down the amount of PCR testing for surveillance only when it's asymptomatic. I think that's the main things I wanted to just cover in the rat space, and just trying to pick up if there were particular issues. There's no rat to be done at clearance and PCR at clearance. So some of the other states had in there around a day 6 rat test and then release on day 7. We don't have that here. There's no solid evidence to utilise that as a mean to say that that's an acceptable clearance criteria. We know that some people have been completely negative on rat the whole time and been positive on PCR. So it is still a requirement to to do the full 10 days, and there's no requirement for a swab at the end. So if you're returning to a high risk setting, you do not need to have a PCR test at the end of those 10 days, and same with an antigen test. We know some people do it for fun, just to see if they've cleared and how infectious they are, and we know that antigen tests are good at looking for how acutely infectious someone is. I might move now to Mel. Mel, if you've got any specific areas you picked up in the Q&A that you want to talk through.
Still lots of questions around the infusions, and I've tried to answer as many as I can, and hopefully once we can get that website address out, that will probably answer a lot of them for people. Generally, I think also there's a lot of questions still around close contacts and exposure matrices and implications of being a close contact for a positive case, particularly for healthcare workers, and how RAT testing will be becoming a part of the process for sort of clearance to return to work, in potential for that kind of reducing the time spent in quarantine if needed. So there's still some finalisation going on around the new matrices, which will no longer be complex enough to actually be matrices on close contact analysis. And I think Emily's posted the link to the website in the chat. Thank you. And yeah, so and just trying to access RATs, as you've said, Emily, already. So I think they're sort of the main themes that I'm seeing, and obviously people's concerns about their patients being able to get through to the CRCT and access the care they need. And I will say that there has been significant improvements in waiting times and people actually being able to get through with our new phone system. So, and email's also good for getting messages through from GPs to me, and then I can escalate. So I think that's all I can answer off the top of my head on the webinar. Feel free to jump in anywhere, one else.
I just saw a question posted around timings for booster after COVID infection, also timing for COVID vaccine after a child in year 12. I think that just in terms of, I think it's a really good point. I will just make mention around the boost. This is a real area for conversation at the moment, is around booster doses post acute COVID infection, because there's obviously we're in a period now where we're looking at mandatory booster vaccinations required for healthcare workers. There is active conversation happening in this space because ATAGI haven't set a clear position on the requirement for boosters post-acute infection in a timeline. I mean, certainly the immunology advice has been to leave it for 2 months after an acute infection to get a booster dose, not for primary course, but for booster dosing, noting so because of the fact you want to get the biggest bang for your buck with your vaccine. But of course, it doesn't then align with an exemption criteria at the moment for the vaccine booster doses requirement. So we're just working through those requirements and waiting for a little bit more advice from ATAGI, and we have reached out for that to come back in. So once we have clarity, we'll provide that out. There is certainly no harm in having a booster dose post-acute infection. So the advice currently we give out is as soon as your acute symptoms resolve that you can have a vaccine, whether that's a primary course or a booster being given. However, we do know that that really to get a really good immune response, it's best to leave it sometime after you've had an acute infection. However, we know now with Omicron Delta, it's a little bit more complicated in that space because you want to obviously be protecting yourself against Delta, which we know is still circulating out in the community, but of course, Omicron being the predominant strain that we're seeing, variant that we're seeing at the moment. So we're just, once we get that advice back from our clinical advisory group and additional advice from ATAGI, we'll send that and update that out. But thank you for posting that into the chat. And really around children as well, the same thing with children. It's a little bit more complex again because of the fact with the different variants and how this is fitting in with vaccination. But for primary course, the advice still is as soon as the acute infection resolves to get vaccinated straight away. For boosters, that's where the conversation lies. So still for children who have had an active infection, once symptoms have resolved, then they can have a vaccine if they're aged now between that 5 and 12 age group. Jackie's just posted in here, and I think it's a great point. Thanks, Jackie. Around 90 days post tropamab as a vaccine response won't be as good. That's absolutely right. It's all around building up the latest immune response and and seeing how people respond. We do know that you do get protection with booster doses against Omicron, but it's just around how long that immunity lasts for. That's probably the main things I just picked up there. There's still quite a number of questions coming in through the chat. We've had a question around do you need to notify CDCB of a positive COVID case result. Everything, it is automatically notified, but of course with RATs going live tomorrow, being acceptable as a COVID positive result, there's a requirement to enter it into the online web form, the individual themselves or someone can do it for them, or you can call up the COVID information line. We've got a special dedicated call line now specifically for rapid antigen tests, which has been fantastic that we've been able to launch that today. So people can call up if they don't have access to the internet or English as a second language, and they can then access an interpreter through that service as well to register their test result, and the team will be able to enter that for them into the system. So then they'll be linked into our CDCB team and then into the COVID response care team. Now, if someone has no phone at all, we actually have a number of other ways that we contact people. So we use SAPOL visits. We do have a number of visits per day that go out and check on people as welfare checks. And then we also now have integrated across into our EMR systems as well. And we're working very closely with Department of Premier and Cabinet to see what other information we can pull from different sources to better gain people's risk profile and also their contact details as well, because we absolutely do need to make contacts. That was a great question that came through. And so with individuals without phones, there are absolutely processes in place if we can't get hold of people. And we do send SAPOL out quite frequently to check on people. They're probably the main ones coming through. We're not expecting vaccinations in the 0 to 4-year-old age group anytime soon. I think that's due to the fact we need a lot more study trial data, so that's not expected. And I think there's a number of questions come through, but we'll try and answer some of these as well. All right, anything else from our wonderful panelists tonight? Jenny Gould, Danny, Nan, Mel. I am going to make a comment around, oh, Danny, you've got a question. I was just going
I was just going to say.
You're waving to us.
Goodbye to everyone online.
I was going to make a comment about PPE supplies. I think we're all aware that there's currently quite significant shortages of PPE out and about, given a lot of people have stocked up, particularly in other industries. And just for awareness as well, that there are orders coming through to the PHN. However, there's been delays in terms of the ability to transport those PPE supplies into the PHN. So we're hoping to get some resolution for that soon, but otherwise we'll be utilising our state stockpiles to be able to support general practice until those supplies come in from the Commonwealth. But unfortunately, it has been an issue that we've seen stocks reduce.
Thanks, Emily.
Can I just, sorry to interrupt, can I just quickly mention about sotrovimab for children? So we can give sotrovimab to 12 to 18-year-olds if they fit certain criteria, which are built into our screening criteria for COVID kids quite deliberately. But we are a little bit harder on the risk factors. So we haven't given it yet. We've certainly screened 2 people in to receive it should they become symptomatic, but they haven't yet. So just so that people know, we are doing it, and we're doing it we can do it through our face-to-face centre.
Thanks, Nan. There's a few other questions I might just go through around seeing patients post clearance of COVID, and should you, a question around should you consider seeing your patients outside even after 14 days. Look, there's not really a lot of evidence for that. What we do know is, particularly with Omicron, it's really around that day 3 to 5 that people are infectious for. We run a 10-day process here in SA that's 10 days of isolation, and then it's a flat 10 days. So regardless of the symptoms, unless someone's admitted into the acute space, it's 10 days. So it's very safe for people to be seen. But of course you'll have mask requirements on. So I think it's important. I know Jenny often talks about this in other webinars, that we want to reduce down the stigma post-COVID as much as possible, and normalise the fact that we're going to see a lot of cases here in South Australia. We've already had a large number of cases here that we just need to accept now that we have to put those measures in place. But once people are cleared, they should feel safe to be able to go out and about. But of course, we still have mask provisions in place, and we do encourage that as part of the clearance process, that people maintain the same level of PPE and the same masks required as what they would do in other settings. The other thing I thought I would just mention is around the close contacts matrices. There was a really good matrix that went up online, which was around the positive cases and the close contacts and the household contacts. We'll post that in the chat. I might have to find that link somewhere in my emails. I was sending it around yesterday, but it's an excellent little chart that actually explains it really well around those timeframes of how long people stay in quarantine or isolation for, depending if they've got COVID. And a good point to emphasise here that I was trying to emphasise with the close contacts matrices is that it is important that people are in that period of quarantine for the 7 days. That's still really important to be maintained. And whilst we hear about essential industries such as the meatworks and critical areas where staff had to come back in full PPE, there certainly is not the expectation that in general practice and community care that you'd be able to come back earlier than the 7 days, given the fact the risk is, we know, so highly transmissible with Omicron. It really is in very specific workplaces, and we've had specific cases in disability where we've had people come back into care for COVID positive patients who themselves have been well enough but have been COVID positive because of critical staff shortages. And I'm sure you might have heard of that in the media as well, that's been the case. So I just wanted to emphasise that point around essential critical workers. But we are looking forward to having the primary care matrices updated and available hopefully the next day or so, just to be really clear around what is classified as that casual and what was classified as a close contact now that casual contacts are not part of those. We don't call casual contacts anymore. All right, Danny, Mel, Jenny, anything else? Any words of wisdom you'd like to leave with our GPs, primary care practitioners, dentists, pharmacists, allied health professionals, child protection? We've got lots and lots of people online tonight.
Yeah. Look, well, just on behalf of everyone, this has been fantastic. Great update. As usual, GPs that and all the primary care just thirsting for knowledge, because everyone just wants to do the best for their patients. Just on that COVID stigma sort of thing, my guy who went to the Royal Adelaide got pneumonia, etc., and he's fine. And he's just desperate to come and see me, booked in, and I'm sure all he wants to do is come and have a chat about it all and get it off his chest. So definitely no stigma. I know this lady, she's a hairdresser and she's day 10 and she's going to work on day 11. Why not? That's fine. Thank you. Thanks, everyone.
All right, we'll leave it there. There's quite a number of open questions that I just desperately want to type in and respond to, and I'm just not quick enough because I've got distracted and talking too much. But what I want to say is just a really big thank you to the PHNs, and particularly Adelaide PHN and Country SA PHN have been so supportive through this process and really working with us around developing and refining these pathways. Now that we're very keen to get general practice back involved in this space, particularly for the mild patients, just emphasising that. And we are working to get GP details back onto pathology reporting forms for COVID-19 tests. We do currently ask for GP details. Since a couple of days ago, we started the process of asking on our survey that gets sent out from Salesforce, which is the CDCB Public Health Risk Assessment Survey that's sent out. And so we're just working through what we're going to use those details for, how we're going to be able to communicate out given the large volume we have. But it is helpful, particularly if our nursing team do need to find out more information, that they've got the details of who their GP is. But of course, we're just so grateful for the support and for the GP support in this space, and particularly in helping your patients navigate the system. We know it hasn't been easy because there's been so many changes. So we're keen to make sure we can try and get some more information out this week now that we've changed our processes over to really incorporate Health Direct to a great extent and usual GP primary care support as well. All right, we'll leave it there. So thanks, Crystal, for hosting tonight through Adelaide PHN, and we'll make this recording available. What I might do, I might go through and try and answer some of these questions, if that's okay, Crystal, if we could leave this live, if that's possible. Just for
of course we can. Yeah,
Fabulous.
no problem.
All right, we'll leave it there. Thanks so much, everyone. Take care.
Thanks, everyone. Bye.